Hi, my name is Alon Orlev. I'm a cranial neurosurgeon working in Tacoma, Washington. In this video channel, I'm going to be discussing various cranial pathologies and conditions, mostly meant for patients and families and anyone really with an interest. Today, we're going to be discussing awake craniotomies, surgeries that we do on patients while they're awake. So let's dive in. Okay, so let's start with the brain model. So we know for roughly 100 years already that there are different areas of the brain that are in charge of different functions in our body. The brain has areas that are in charge of speech, areas that are in charge of vision, areas that are in charge of moving, areas that are really in charge of any of the functions that our body does. Some are governed in different regions that are on the cortex, some are more deep, and some are actually in the brainstem. We don't know it all. We know that as we have more and more research coming in about different areas in the brain, we realize that there are areas that we didn't know their function in the past or thought that they didn't have a lot of function that are actually quite important. And as we gain more information, we can be better at doing surgery in the brain without injuring important functions that the brain has. Some of the studies around that are evolving all the time. And a lot of it is the DTI and functional MRI. Functional MRI tells us which parts of the cortex, of the outside layer of the brain, are in charge of doing specific tasks or functions. DTI, or diffusion tensor imaging, it's another type of MRI where we see all these beautiful fibers with all these colors. And that actually tells us where the fibers are and what areas of the brain connect with what other areas and how the brain connects down to our spinal cord and to the rest of our body. So that's all evolving. But when we want to do surgery on a lesion that's inside the brain, we have to do it very safely and not injure areas that have function, because oftentimes the first goal of surgery is not to injure our patients. And the second goal is to be able to remove as much of the lesion as we can. And again, that sort of varies by the lesion, but that's sort of a general concept that we all try to live by. How do we actually map these areas? We often do that with an MRI before surgery. And how do we, during surgery, make sure that we don't injure those relevant areas? So we have various tools. One of them is neuromonitoring, where we actually use electricity to run it from a certain area to the brain over to the body, and we actually put electrodes in different areas along the muscles, and we use a little probe that we touch different areas of the brain, and we can read those functions in the muscles and then know that we're actually close to motor regions, for one. But some areas of the brain are either hard or not accurate, or at this point, we can't do good monitoring while the patient is asleep. That's when awake surgery comes in. Let's discuss some of these areas. So the first and very obvious region that we can't really monitor while the patient is asleep is speech-related regions. So we know that in the brain, mostly on the left, there's a region on the frontal lobe called Broca. There's another region in the temporoparietal lobe back here called Wernicke, and those are speech-related regions. One is receptive and one is in charge of actually producing the speech. That's a frontal one up here. And there are fibers that connect between them called the arcuate fasciculus, which is part of the superior longitudinal fasciculus. When there's a lesion that involves any of these, whether it's these regions of the cortex, the outside of the brain, or the fibers that connect them, often patients suffer from speech problems. They have a hard time saying what they want to say, or unable to understand language at times. Regardless, we want to do surgery where we avoid injuring these even more. Now, this is a type of surgery that we can't do when a patient is asleep, because we have to have the patient speaking as we're removing the lesion in order not to injure regions that are important, whether it's the cortex or the fibers. That's one indication to do awake surgery. There are others as well. Some surgeons use the motor regions, the regions that are in charge of moving the side of the body. The left motor strip is in charge of moving the right side of our body, and the right motor strip is in charge of moving the left side of our body. If we have a lesion that's anywhere in this region, some surgeons would do this surgery awake as well, in order to have the patient do manual tasks, move their arm or their leg as we're removing the lesion, in order to try and avoid injury. And when we see that injury is beginning, or when we're getting very close to regions that we perceive that those are the regions that are actually the very specific regions that govern the function of a limb, that's when we often stop. So generally speaking, awake surgeries help us monitor function that we can't do well enough while a patient is asleep in order to be able to, as I mentioned before, achieve our first goal, which is not to injure our patient during surgery, and achieve the best we can, our second goal, which is to remove as much of the lesion as we can. If you'd like to get more information about awake neurosurgical procedures and see an example of one, you're welcome to watch the next video where I show one of my patients and sort of describe the procedure that we did. Let's go.